Our session was on the country experience on implementing community health policies and strategies, and I just gave a brief overview of how USAID has been supporting community health, and then talked a little bit about my own experience in a number of different countries, and then spoke a little bit about Nepal, because unfortunately the delegation from Nepal wasn't able to come to the conference. So in terms of USAID, we have a really long history of supporting community health. It goes all the way back to what were known as the Child Survival Grants, managed out of Johns Hopkins University, but funded by aid way back in the 80s. And over time, those evolved into being not just for child health, but more broadly for RMNCAH grants, and they evolved from being grants for only American organizations to being a bit broader. Now we're at a point where we're no longer providing those general grants for community implementation, but we are looking at very specific activities to kind of get at some of the core issues or barriers to improving community health systems. And also, we have a number of organizations that we fund that provide technical assistance in various ways at the community level. So MCSP, and various other organizations that have been here at the conference. Not to mention that our country offices, which is really where things happen in our country missions, they will often have partners engaged as well. So the second part was I helped put this panel together, so I used my power, as it were, to stock it with people from countries I've served in where I think there have been interesting community health stories. So Madagascar and Kenya were on the panel. As I mentioned, Nepal, another place I've lived and worked, wasn't able to make it, and Zambia, there wasn't enough room on the panel. So the main point I was making about those countries is they have very different kinds of experience, both historical, strategic, policy issues, geographical issues, and really what we were hoping the panel would do would, start to bring out some of the breadth of experience that different countries have and what stages they are at in various issues, to help jumpstart the dialogue between all the different country delegations that are here at the conference. So I spoke a little bit about Nepal, which is a female community health volunteer program that is over 20 years old. There are now 50,000 female community health volunteers. When we first started, a large majority of them weren't even literate. And they started out providing some very simple services, like refilling oral contraceptive for women who'd already started on them, and providing condoms. Over time in the 90s, there was consensus to add to them the ability to diagnose and treat with antibiotics respiratory infections. They began to provide Depo-Provera, and so their role expanded. They were also incredibly instrumental and really the key in Nepal's extremely successful vitamin A program, where vitamin A was distributed nationwide every 6 months, and it couldn't have been done without the FCHVs. Over time, the same issues that many other countries are dealing with have come and gone for Nepal. These are volunteers. This is starting to get to be a larger job, as it were. How do you keep people incentivized to volunteer? How do you supervise and mentor them? And at one point, Nepal had a lower level salaried cadre called maternal child health workers, who were supposed to be the link between the facility and the community, and who were supposed to supervise the FCHVs, but that cadre didn't last. And so, these things continue. The other thing that was very nice in the beginning is we used some of the activities that were going on in literacy with the community health volunteers. So we worked with those groups to provide them both literacy and numeracy skills. They also had that was considered an incentive, but also an important way to improve the adult education of women in Nepal. At the same time, a lot of them became involved in various income-generating activities. In some places, communities or local government would set aside some funding that they could use for borrowing or to do some activities. Lots of different things have been tried. I think where Nepal is now is they're trying to decide how this program can or should change with changing situation in Nepal. In many communities, you have women, thankfully, are becoming much more educated. As they become more educated, often doing this much volunteer work either isn't an option because hopefully they can do paid work, or this is something they're less interested in. So that's one issue. The other issue is that in more urban areas or more less rural, so not necessarily urban, but less rural areas, the needs are different, and the community health volunteer model may no longer fit that environment and may need to be changed. So there's a lot of discussion going on. Also, you can't even begin to think about paying 50,000 people. That would break the bank before you started. So Nepal's at a point where they're trying to see how this program can be adapted. And then I also just mentioned, in Zambia, the community health worker program it was not as institutionalized from the beginning. So they're at a point of looking at harmonization of different kinds of community volunteers. Kenya, who gave a great presentation, talked about what happens when you have a national strategy and then you have devolution and you have your subnational units, the counties involved, charged with delivering health services. And then what should be common among the counties, and what can counties do on their own, particularly around making decisions about some sort of stipend or something for the volunteers, and what's the array of things that they should do. And Madagascar, where again the volunteers have been more institutionalized, talked about some of, again, their challenges. How do you harmonize different volunteers? What do you do about paying or a stipend? What if the donors have been paying it? So I think it was a good panel to just bring out some of the key issues, nicely capped by the WHO colleagues' presentation on some of the research and literature review they've been doing on different issues, to kind of start the dialogue.